Good morning, everybody. Thank you for joining us today. Jana on my side is the program manager on the telemedicine program, and I'm the CEO who works with the Minister of Health on starting the telemedicine program. As we have been traveling and meeting a lot of communities in Guyana, we learn about a lot of the different suicide cases that's happening in the country nowadays, including specific cases that touched of community health workers, family members. As we had discussions with the Minister of Health, the Director General of the Ministry, we realized what an acute problem it is. And we talked about different ways of handling it. And we realized that the people who have the most opportunity to really have an impact are you, the community health workers and the educators in the field who are meeting and knowing and interacting with your community members. So we decided to try to put this webinar together to share with you different tools and methods, share ideas between the two of you, get advice from some of our esteemed doctors in psychiatry and the mental health unit, and try to provide you with some basic tools on how you can help your communities. Before we start, I know it's a different cultural context, but we thought we will share with you a video that was produced in the US by a school and a couple of students after somebody in their community committed suicide. So let us start with this. Right.
Our teachers are educators,
role models,
mentors,
community leaders,
a smiling face when I walk down the hallway,
a person to go to when I'm having a bad day.
Some of the most important influences in our lives.
You probably get to know us pretty well.
At least, what we let you see. Of course, you see me in class.
and then there's the rest of me, beyond the schoolwork.
There's a lot to balance with full course load and extracurricular activities.
soccer practice,
Picking up my siblings after school.
My job at the grocery store.
You probably get used to each of us acting in a certain way.
Being in a certain mood and having certain patterns.
And you might notice other times when we're not acting like ourselves.
We might act.
Extra quiet, like not participating in class or talking to our friends.
And usually tired, with our head down on our desk.
Slow to hand in homework, or we might stop doing it altogether.
Just plain irritable.
Jumpy or quick to anger in a way that seems out of character.
Like we just don't care.
It might be nothing.
But we might be really struggling.
We might say,
I can't take a test.
I have to go to guidance. I might even ask repeatedly.
We might be
having a hard day or week.
Having a hard time finding the right balance of schoolwork, activities, and the rest of life.
Or I might feel worse.
Like a failure.
Unliked.
Hopeless about the future.
I could be depressed.
Or so anxious, I'm immobilized.
I might feel unable to come to school.
I might not be talking to anyone.
I might feel like I can never live up to the standards I think others have of me.
Or I have for myself.
Things might be rough outside of school.
I might be fighting with a friend.
Or going through a breakup with a partner.
I might be using drugs or drinking to cope.
Living in a home that's filled with disruption or even violence.
Or struggling with acceptance about my gender identity or sexuality.
Like I can't go on like this anymore.
I might be thinking about killing myself.
It happens more than you think.
And when it's too late, people say,
I had no idea.
I thought it wasn't that bad.
I wish I'd said something.
How could they have been in my class all that time and I never knew?
And sometimes you can't know, but lots of times there are signs.
If a student isn't acting like themselves and says they can't take a test or turn in an assignment,
Don't start by saying, you have to, or you'll lose credit, or everyone else is doing the work and taking the test.
That might be true.
but there will be ways to follow up on the missed work later.
We know you think our emotional wellness is more critical than one test grade or homework assignment.
We know you're trying to be fair with class rules, but we might need some flexibility until we're okay again.
We also know, as a teacher, it's hard to find time to talk.
But if you think something might be wrong, the only way to find out is to ask.
So, step 1, ask questions.
How are you doing?
Is everything okay?
Do you want to talk?
How can I help?
Do you want to go to your counselor?
Or the nurse?
Do you want to stop by after school?
Asking a student who may be struggling with thoughts of killing themselves if they are suicidal shows that you see them and that you care.
You can ask, are you feeling so badly that you think about killing yourself?
You won't be putting the idea in our heads.
Mentioning it could be our wake-up call to get help.
Step 2. If we say we're suicidal, start by listening.
Don't immediately try to talk us out of it. Stop and listen.
You can say that you're sorry that we're feeling this way.
Say you'll make sure we get help.
That you are here for us.
That you will support us.
And give us hope.
Say you know other kids and adults feel this way at times too.
Make sure you know your school's protocol for how to get help for students in crisis.
Do not leave us alone.
Even if we say that we don't want to talk, say that you're here for us.
Even if we don't want help or ask you not to tell anyone,
Please do.
Even if we don't appreciate it now, there's a good chance that we're going to appreciate it later.
you could be saving a life.
Thank you for all you do for us.
And thank you for listening.
Okay, everyone, this was a clip. So why are we meeting on a Sunday morning to talk about suicide prevention? By communicating with different communities, we've realized that it is something that's not uncommon, something close people have experienced in their close circle and their families. So today we are bringing 3 psychiatrists together to talk about suicide prevention techniques and how to identify suicidal thoughts in your community. And for this, I just briefly want to introduce the 3 psychiatrists we have. So I would just ask Dr. Fredericks, Dr. Nikram, and Dr. Henry to unmute themselves and just do a quick introduction before we continue.
Hey, good morning, everybody. My name is Dr. Sion Fredericks. I am a senior resident in psychiatry at the Georgetown Hospital. Really glad to be able to help in any way today. Thanks.
Thank you.
Morning, everyone. Oh, Henry was going to say something.
Well, you can go ahead. Thank you.
Oh, you're going to let me go first?
Yes, please.
Such a gentleman. I am Dr. Elizabeth Nikram. I'm a psychiatrist, and I've been practicing in psychiatry for the last 12 years. I'm happy to be here also, even though I'm a bit sleepy.
Good morning, everyone. Good morning, everyone. My name is Stefan Henry, and I'm also a psychiatrist since 2019, and I normally work out of GPHC, but we also do clinics in Lenora, Perica, and some other outlying areas. So thank you for having us today, and hopefully we can tell you something that can help you help someone or even help yourself sometimes too. Thank you.
Thank you for the introduction. So, okay. So today we're going to talk about how to identify members in your community who might be having suicidal thoughts or depressed, how to find the right techniques or the right resources to help those people, and how to engage with them in further treatment. Before we start, we just briefly wanted to talk about the distinction between sadness versus depression. Mostly sadness is a feeling that most of us had at some point, while depression is something that's more severe, long-lasting, and impacts a person on a deeper level. So I just wanted to put it out here first before we continue. And then we will share these slides afterwards. But
Jana,
here
may
are-
I add to that, please?
Go ahead.
So sadness is an emotion, and the word emotion means to move. And like all other emotions, when we feel sadness, it's because something is not going right in our life, and it's our brain's way of saying to do something about it. Whereas depression, it usually has no source, or it's too big for the source that is present, and no matter what we do, it does not go away.
Thank you for that. Would you also like to dive into some of the identifications of this, or should I just leave it here and then we have it in the slides afterwards for people to look back into?
Actually, what I wanted to do, or how I wanted to start this session, is that you have listed our objectives. And so I would like to hear if anybody has, anybody in the group, the training group, has any objective that was not listed, a personal objective, that something that they want to take away or learn from this before we go on.
Okay. So maybe I can stop sharing. So we're back in a group call. So yeah, if you just want to unmute yourself and maybe quickly introduce yourself, tell us what's your name, what's your profession, and what you would like to take away from the webinar, why you joined early this morning. You can just unmute yourself and tell us.
So we don't have to go through everybody, but just if there's anybody who has an objective that is not a part of ours. Like we stated some very broad objectives in the start of the session. So if somebody has an objective outside of that, they can let us know. Miranda, would you like to say something?
Morning. No, that's fine.
Okay. All right. So we take it that the objectives that Miss Jana listed, those are the ones that everybody else they have in mind for this session.
Okay, great. Then I'll go back to sharing the screen.
Okay.
There we go. What's this? Oh yeah, then I would move it on to you, Dr. Sean, if you want to take over.
All right, great. Morning again, guys. So for this part of the session, I think I just wanted to focus on how we approach patients that we or individuals that we suspect or patients that we suspect of having suicide ideas, patients at risk of suicide. So I wanted to put just certain things in context. Just touch a bit on some phrases, terms that you would find us using, you would see in the media or in literature. So I have some here: aborted suicide, self-harm, lethality of suicide, was it suicide ideation, and what's suicide intent? Just some things to go through, because all of these things you would actually see in a person's history, especially somebody with frequent suicide ideations, right? For example, aborted suicide, right? Um, that's someone who would have made an attempt, but it would have been stopped before any sort of significant damage or significant physical damage was inflicted upon the person's own body. So they actually went to do something. They were preparing to do something and then they stopped, right? So that was something that's important to know, something that's important to find out about. A lot of times we just ask, you know, persons, if you would have committed suicide, we use that term a lot. If you'd ever hurt yourself before or things like that. And the individual just say no, because they didn't. But then if you ask them questions along the line, trying to look out for like aborted attempts, that might get you a bit more further with them. There are persons who practice self-harm or non-suicidal self-injury, which, the person hurts themselves, but not necessarily with the intention to end their life, right? A lot of times they would explain it as they just do it to feel something, to have a release. They don't want to die. They're just cutting themselves, pinching themselves, pulling out their hair, things like that. And it might seem, odd or a bit frivolous or attention seeking. It's not. But it is a risk for suicide. A lot of persons who present with non-suicidal self-injury, right, or self-harm, a lot of times what they practice, it may go a bit too far, and they might actually cause significant harm. It might even lead to death in some cases, especially those who you would find cutting their wrists. Okay. Well, lethality just refers to the level of danger that the method poses to the person. And then we have suicide ideations, which is something that I think you guys should try to focus on in your communities. Always try to ask about it. A lot of persons think that when they ask persons about their suicide ideas or about thoughts of self-harm or thoughts of dying, I think we naturally feel like we're putting these thoughts into a person's head, but that's not really the case, right? It gives the person a chance to actually open up, to feel seen or heard, and they might actually divulge a lot of how they're feeling, what they're planning on doing, and more importantly, why. All right. So your suicide ideation is basically the person's thought about their own death, thoughts of dying, and all those aspects that come with it. So it's important to find out about that, how serious it is, and what they have planned. All right. And then there's intent, which is just the different levels of or severity of the person's expectation of how if they're gonna die with whatever they intend to do or whatever they would have done. All right. So a lot of persons, they would have attempted, made an attempt, and then it's good to assess the intent. Was it just something that's impulsive? Was this thing planned out? It's very different. Someone who, went through something extremely traumatic or hard a few days ago, they were feeling overwhelming sadness or even depression afterwards. And they just impulsively decided to take a few pills to ease the pain, so to speak, versus someone who would have been giving away their possessions for the past week, writing notes, feeling hopeless for over the past 2 weeks. They're just giving up, right? There are different levels of intent that we should look into, and it's very important. So as I thought, these were just some key terms that you guys should know about and things that you should try to always remember to find out about when you're interacting with individuals who are at risk. Okay.
Yeah, and may I add
Yeah.
something?
Yeah,
Jana,
sure.
can you go back? Yeah. So there are other definitions. There are multiple when it comes to suicide. There are many terms that we can define. Two very important ones not on there is the suicidal gesture and the suicidal threat. This is where
All right.
people
Yeah.
they they want to make you think that they want to kill themselves, but they don't really want to kill themselves. They just want to manipulate the environment. So the reason why I just wanted to insert that in there is that a majority of persons that I've spoken to who did not have prior training in suicide, they usually think that the person it's a suicidal gesture or suicidal threat. So that is our absolute last thing that we go to. And we only, if we have sufficient evidence, then we say that. But so what I would like to emphasize is that the order here is not that we think first that this may be a suicidal threat or gesture, and then we go down the line and then we say, oh, well, this might be more serious and it might be a suicide. The patient might be having genuine suicidal ideations and they might have had an attempt with true intent. What we do is that we put attempt with true intent at the top, and that's the very last thing at the bottom, the gesture and the threat. Okay?
Yeah, with you, we don't play around with suicide. You always assume, right, or prepare to deal with the most severe scenario and come down. Yeah. Right. So, for you guys, I think it's important to know how to go about approaching the patient, how to assess the patient. Having those different terms in mind, what you look out for. The key thing, are we going to get into rapport building in a few? So, having a good relationship with the individual, with the patient. Obviously, that's very important. But specifically with gathering information about suicide, we need to try and delve into whether or not this patient has suicide ideations. If they have any plans, how structured or developed the plan is, and what are some of the symptoms surrounding it, or situations, I should say, sorry, surrounding the suicidal ideations. The precipitating factors, we say sometimes, was it domestic issues, was it financial issues? All of those would come into the risks. So the next thing would be the risk factors for suicide, right? So in communication with these patients, we really try and see what are the root causes that are making this person feel the way they feel, or lead them to some of the decisions they're making. All right. There's a whole list I think I put on the slide too. We're gonna go through of risk factors, and risk factors could be associated with the person themselves, right? And that's when we speak of persons who are clinically depressed, persons with significant anxiety, persons who may have some other diagnosable mental illness, persons who practice, who use illicit drugs and so forth. And then there's stuff related to relationships or family, and then others that is generally in the environment. A common one I think goes underrated here is the contagion effect. I don't know if anybody realizes here, when you hear about a suicide in the media, there's usually a cluster or recurring suicides afterwards. You hear somebody completed suicide a few weeks ago, then you hear another one today, and then another one, and it just seems to keep happening, especially when it's put in the media like that. That in itself is a risk, and that's why in some countries they don't go into the method that the person use for suicide. They don't even put some of the methods in media as
Because
well.
it's sensationalized it and makes it seem like a romantic way to die. And then everybody's like,
So
oh, I want to go out like that now.
a lot of people see how relatives and loved ones and so respond, how the masses respond, and then they're going through their own thing. So that in itself is an environmental risk factor, but we didn't get into this later. So once we have this information, once we know, okay, this person definitely has suicidal ideations, they have suicidal behaviors, whether it's non-suicidal self-injury, did they have aborted attempts, did they have repeated attempts? Once we have that information, once we know the intent that they have, once we've assessed their risk factors and protective factors, it's time to know, as a team, and in collaboration with the patient, always figure out how we're going to help this person, right? It's good to individualize care. It's not like an infection where, as doctors, we accustomed to just this one antibiotic. It's going to most likely work for most of these infections. You try to individualize care because your reason for coming to clinic today and discussing your thoughts, feelings, the reason why you want to end your life or just don't want to wake up in the morning is going to be different from the next three persons who come with the same complaints. Okay, and you can't just really use a blanketed approach for the individual. Well, what we could use is blanketed resources for them, right? Which knowing how to engage with these patients is one. That's a blanketed resource. But how we actually deal with them, it would be better if each person has their own their care tailored to them. All right. So that's where the clinical decision making comes in. Should we just have this person speak to a counselor? Could they even talk with leaders in the community? Because the issue at hand might be something a bit more social or socioeconomic, that's causing them to feel frustrated, and maybe that ease alone would help them. Do they need to follow up with a mental health worker within the community or via the telemed system, or do they actually need medical intervention? Right. So that's where the decision making comes in once you have gathered all that information. Okay. Anything, Dr. Henry or Dr. Nikram, you guys want to add?
Yeah, I think it's important to add that since the last Mental Health Act came out, the decriminalized like locking up people for having a suicide attempt, or people who attempted, even though we never did that, we never practiced that, but that was one of the things that made people not come to seek help most of the times. And another important thing is that everybody that you see, if you're like a first responder or somebody that goes to see the patient when they have a suicide attempt in the hospital or in the health center or anything, even though you might see that they have like a low risk, I think we're going to look at that a little later on, like a low risk, there's always a risk. And you have to really consider all your factors, their social support, their ways of coping, all of that. You have to really consider to decide, if you're gonna send home that patient or if you're gonna admit that patient or keep them in for 24, 48 hours. Of course, you have to consider the method that they tried and the clinical factors as well. Okay. Thanks.
All right. So I just thought these were some useful suggestions regarding how we approach or how we talk to someone or interview someone with a risk of suicide. Okay. And a key mistake a lot of us make, I used to make in my medical career before even joining the psychiatric program, was one, not asking about thoughts of suicide or self-harm in the clinical setting. Maybe this is just anecdotal, even in the follow-up in the postnatal clinics, in the postpartum clinics, when you follow up with the mothers at the 4 and 6 weeks. It's I hardly recall that being like a key point that people would stress on when interviewing those patients, and in other clinics too. Those that are dealing with the elderly and so on. You don't ask about suicide. So that's something that we don't do. If we think this person is at risk, you find out about it. And then in finding out about it, one thing to avoid is to avoid asking negative questions, questions that are phrased more negatively, right? Because they actually found that when you ask things like, see, you just don't really feel like killing yourself, right? You would actually the patient is more likely to say no, right? Or you never do anything in the past that would never do anything past like try to hang yourself or anything like that. The patient's gonna say no. And then
Why
you
is
can
that,
just
Sian?
retard it as a pardon?
Why do you think that is?
It's a leading question, right? And not just that, it's closed-ended, right? It's just not a good approach. It's for us, it's better to have open-ended questions that allow the person to um actually discuss their thoughts and feelings more.
So also what it does is that whether we realize it or not, when people come into contact with us, they think, oh, this is a doctor or this is a
Yeah.
medics or this is somebody important, and I don't want to disappoint them. So when you phrase the question like that, they know you're expecting them to say no, and they don't want to disappoint you. So that's why they do that.
And the interesting is it's not just about suicide, they do it with stuff like taking the tablets. So if it comes to simple compliance, see, imagine stuff about, thoughts or acts of harming themselves, right? They just wouldn't really divulge that. So that's why we try to be a bit more understanding, empathetic with individuals, especially when it comes to these topics. Okay. So the first key thing that you guys could practice um would be opening with asking a general question about your thoughts and feelings. Right. And an example here that I give is, do you find yourself wishing for permanent escape from life? Right. Right. Or is it safe to say that sometimes you feel overwhelmed? Or do you ever feel overwhelmed with life or things like that? Right. And then you listen to what the person has to say. Right. Um, if what they have to say is laden with a lot of stressors, a lot of stuff that qualify as risk factors, um, you can then ask the person, do you think about your own death sometimes, or do you think about dying sometimes? All right. Because you need to ask about it, right? And it might not even be about death or dying. It could be about hurting yourself, about self-harm, right? And again, yeah.
Maybe you can rephrase those questions using normalization, because that might be a little bit more helpful for them. Give them an example. So maybe you can say something like,
Yeah.
when people are feeling the way that you feel, or when people are in a situation like what you're in, sometimes the brain starts thinking that it might be better if I wasn't here, or if I should die. And then you can ask them if they feel that way. Sometimes we do that in psychiatry, and it's quite useful because it sets the stage to say, hey, this is an okay thought to have, and you can tell me about it.
Yeah. So where are we on? The inquiry about death, right? No, I think we were still on the last one. Oh, right, yeah. But so the last point with that was getting them to actually describe um those thoughts, right? Especially going into if they do have a plan, if they have been thinking of self-harm. Um, like what is it that they actually plan to do? Especially timeline, method, all of these things. If they tried it before, if they've rehearsed it, you know, as detailed as possible. Okay. All right. Yeah. So I touched on, we mentioned this. So a history of suicide attempts is important. A history of suicide attempt um, to any degree is a serious risk factor for persons, okay? No matter how low in lethality the attempt was. Okay. You try and find out what led to those previous attempts. What were the factors that pushed the person to that point? And even though we've been focusing a lot on the negative side, you also ask the persons on the positive end, what are some of the things that you want to live for? You know, you're asking them, why you want to die, hurting yourself and all those things. But you also ask the person why you want to live. So what are some of the things that you're looking forward to in the future? And so on, right? A lot of times it would be family, their kids, their job. They're really looking to get, hoping that this other thing comes true. But this situation right now is just too stressful. Okay. And I didn't want to leave this last one out. Looking for signs of psychosis, specifically hallucinations. A lot of persons, or I should say, it's not uncommon for persons who are depressed to also experience hallucinations, right? They would have their own negative thoughts might actually manifest as someone else's voice or another voice in their head or next to them, telling them a lot of these things. You're not worth anything. You're a bad person. You should do this to yourself, right? And that is important to look for. I don't know if Dr. Nikran would or Dr. Henry would agree, but I mean, these things might not necessarily all be done in one sitting with the individual. You got to gauge your level of rapport with them too. They might not divulge that with you immediately, but you should look out for it or be on alert for it because it puts the person at an even greater risk.
I absolutely agree. I always do this, but I always preface it with a disclaimer, and I'm like,
yeah,
I'm going to ask you something really strange, and just to cover all bases, are you hearing or experience anything that is singular to you that nobody else is experiencing? So I do agree with that last point.
Right. I think, the thought of persons hearing voices and having things like that, I think culturally we just say, oh, this person mad, or that's only for a certain type of person. But these things happen, right? It happens. And, oftentimes, I mean, one of the most important places that you don't want to see it, but you can still see it, is on the maternity wards, the postnatal wards, patients who move from the blues straight to postpartum depression is something that can happen, and it's no fault of their own, it just happens. It's always good to look out for it. It's a serious risk factor, and those voices can actually push the person over the edge too. It tells them, do this, you might as well do this. Okay. All right. Cultural humility, I think, is very, when we're talking about approaching patients at risk of suicide, I think in the context of us as Guyanese, or those of us working here in Guyana, we're not a homogenous society. Fortunately, we got 6 people and then some sharing the same space, different cultural backgrounds, and so on. So we need to have what's called cultural humility, right? Understanding that your perspective based on your perception on life, your upbringing, your morality, and so on it's different to varying degrees. It could be vastly different from somebody in region 6, right, compared to somebody in region 1, right? Or it could be similar but still got some nuances. It's different for the patient and the practitioner, right? And it could be different between other patients too, right? And even your colleagues, it might be different. So having cultural humility is, I think, an understated practice that we should have in general, but especially dealing with these patients. All right. if you look at the second paragraph, studies actually showed that when patients feel, especially patients of ethnic minorities within countries that got, different ethnicities, they actually tend to withhold information from their doctors or other individuals who are from the ethnic majority, right? Or from a different ethnic background, just because they might feel like the person wouldn't understand, or the person might treat them a certain way or things like that, right? So it's important. Exactly. Right. So we need to understand person's background. We need to practice having empathy towards them and their background. We need to have a level of curiosity about where they come from, the practice in their or the practices in their culture, and you kind of learn. You have an open-minded approach to these individuals, all right, and learn, why this might be here. There are things that you would find in region 8 or 9 that are completely normal that you wouldn't find in region 3, and vice versa. Okay. So I think it's a very key thing to have in mind when dealing with patients. So the rapport building. What
Yeah.
is rapport building? Why is it important? How do you cultivate it? Right. So rapport, yeah, Jenna.
So this
No,
is
thank
my slide, but if you want,
Yeah.
you can go on.
No,
But it's
you go on. You go on.
you. Flow.
We'll
So,
we'll both go in it. So you can
okay.
go on, Dr. Nikram.
All right. So rapport refers to how information is exchanged, and it means when there is rapport, there's a smooth exchange of information between the physician or the nurse or the community health worker or the teacher or whoever it is with the other person that they're speaking with. So if rapport is established, it's very important because people are more likely to give more information if the rapport is good. Of course, if you look online, and for those who are interested, you can have a more scientific definition. Okay. So how do we cultivate it and what is harmful to it? So myself and Dr. Fredericks, we will role play 2 scenarios, and I will randomly pick 10 people from the list of participants afterwards to have some comments on this scenario that myself and Dr. Fredericks would play. Okay? So we're going to run it for 3 minutes. Jana, I'm just going to time it. And okay, let me just send you a message, okay?
okay, I'll let you know when the 3 minutes pass, no problem.
Okay, sure. All right, so enter scene.
Can't act. All right, so I'm the doctor, right? Or yeah. Okay. Morning, Mrs. Nikram. How are you today?
Actually, I'm Mistress Validum.
Oh, sorry, I don't know. It's a Nikram on the chart. Anyway, how you doing?
So and so.
So and so. Why? What happened?
I really can't explain it.
Yeah, well, you gotta try. Yeah, I mean, you come. You must want to tell me something. Try explain it now.
I really don't know what I'm doing here. I don't know why I thought this would be a good idea.
Oh, we could help now. We always try to help those who come. Can you give me 1 second, please? Let me respond to this text. Uh-huh. Yeah, Miss Nikram, you were saying? Miss Validum, sorry.
I don't know what I'm doing here, doctor. I'm sorry. I really can't explain it. I don't know what brought me here. I'm sorry.
All right. Well, if you do feel like talking at a different time, maybe you can try and come back. We're always here. Thanks so much for coming. Anything else you want, you feel like telling us today?
Well, you know, I have been having some troubles in my life, and I really don't have anybody to talk to. And I feel like I need to say it, but it's just not coming out.
How come it's not coming out?
I'm not finding the right words.
Well, you gotta try.
I
I
think
can't pull out the words for you, can I?
no, doctor, I know you can't. I just feel like my husband is being distant, and I feel like I have so much work, and the children are draining, and I just feel like it's a lot for me, you know?
You know, everybody kind of goes through stuff like that. Right? A lot of people got kids, a lot of people got a whole bunch of stuff going on, and they deal. Maybe you should just try and find a way that works for you.
I used to have my grandma alive, and she used to be a really good company for me, but she passed about 5 years ago, and I don't know, I miss her. I feel like I wish I could talk to her.
Okay, okay. You think you could talk to her though?
No, I can't. That is the
Is
sad
it
part.
impossible? It's impossible, right? Well, this is very healthy that we try to move on from stuff like that, right? I know it's hard, but try and deal.
I'm
Anything
having a difficult time dealing, doctor. That is not something that you can. I can't just. I don't know how to switch it off. It's like it's always on my mind, and then when these other problems come, they feel so heavy, even though they might seem small. They feel so big.
you can't try and focus on something else? Isn't there other stuff that is got to deal with?
I guess I could do that. I've been trying, but if you suggest it, I trust you, and I could continue that. It hasn't been working. It's been a while now since I feel this way. Okay, good. Scene end. Okay? Thank you, Jana. Oh my God!
That was a long 3
All right.
minutes.
Yeah.
guys.
All right. So I'm gonna pick 10 people from the. I see everybody is registering in the chat. Jana, why is everybody doing that? Is this for something?
No, I think one person started and people followed.
Okay, so I'm just gonna look at the participants. So I see we
Yeah.
have 78. So I'm gonna call on Abby Stanley. Just now. Let me pick the 10. And Andrea Charles.
Okay. Hello. Good morning.
Here just now. Let me just give everybody a heads up, okay? Charlotte, you too. I'm gonna pick 10 people. Charlotte and Jamela Taylor. And let's see who else is here. Kevin Queen.
Could you also pick one or two of the telemedicine communities? I'm seeing Parima or Chinawang.
You know, Jana, I just have them listed. I have already 5, and so you can pick the remaining 5, okay?
Okay, good. I would like then the telemedicine communities. Region 7, Parima. Region 7, Chinawang. And Region 10, Trail Mile 47. So that's
okay.
3.
You're gonna remember that, okay? All right. So Abby, are you with us? Abby Stanley. Jana, is this person not there?
We just had her, right? She.
No, actually we had Andrea. Andrea is here, but Abby Stanley not here. Okay. Andrea, can you tell me your designation? Sorry, will you tell me?
Yeah, sure. I'm the guidance counselor at one of the secondary school in Region 6.
All right. I'd like to would you make can you make some observations about the interaction between myself and Dr. Fredericks in the little skit we had just now?
Okay. For me, first of all, I think if I was the client, I would not have been open up to him because he's been distracted, right? He's not really focusing on what I came for, you know. And with that, I would not want to be so much open to him. I would not want to share, and I would still be in my problem because he wouldn't be able to help me. I think the rapport, like you mentioned earlier, it was not developed. You know, he didn't get to know me, right? And didn't get to know you, as a matter of fact, because it was the two of you in the scenario, right? So I think he did not build that rapport to get you to open up, and you didn't want to share much.
So good, Andrea.
Thank you.
Thank you very much. So good. The next person I have on the list is Charlotte. Is Charlotte here?
Yes, I'm here.
Charlotte, what did you think about our interaction?
I thought that the doctor was invalidating her concerns when he said that, you know, most people have family, most people have children, and they deal with it. You should just deal with it too. I thought that was invalidating the severity of her concern.
Thank you so much. Yeah, we purposely did that. Jamila? Jamila Taylor? Not here? Okay. What about Kevon McLean?
Good morning.
Oh, good morning. Is it Kevon?
Yes, it is Kevon.
Okay, hi. Would you like to make some observations about the little skit that myself and Dr. Fredericks had?
Okay, no problem. First of all, he missed the introduction part. He introduced himself. He didn't give her a chance to say much about herself. I think her introduction was very important. And then the text message was very distracting that he had to reply to. I think he should have made her a priority based on the situation. And thirdly, when he said that everybody has children and you need to try together, I think he generalized her and he didn't put her in a position to make her feel that, well, you're very important at a moment. So for me, I think that session wouldn't have worked. She would have gone home and probably did more harm than good to herself.
Thank you for your observations. Jana, you may now pick your 5 people, and then afterwards, myself and Dr. Fredericks, we will discuss the learning points behind this exercise.
Okay. I'm seeing 3 people in Chinoang. So can you maybe share with us the observations you made? Oh, 4 people in Chinoang. Didn't see the one person in the corner.
Hi, good
Clara?
morning.
Good morning.
Hi. For Chinoang, my observation, doctor was telling the client about alternative ways of dealing with the issue, but he did not indicate or he did not educate the client about these methods. That was my observation. Thank you.
Thank you. Someone in your group?
Who is it, the guy that's looking so upset at the back there, Jana?
About to ask. In the green shirt.
Yeah.
We invited them to be here.
Okay. No, it's okay. It's fine. It's nice to have y'all. It's just he was looking a bit upset. So I was wondering what happened. It's okay. We can move on.
Let's try Trail Mile 47. What observation have you made during the little skid? Oh, I think you're still muted, ma'am. Just click on the microphone one. Oh no, I think now they dropped. Oh no, there we go. You turned off your camera. Your camera's off and your audio. There we go. Now, oh, audio's still off. I will ask to unmute you. Click on the microphone one more time. There we go.
Good morning.
Good morning.
Hi. For me, yeah, my observation was that the client was very confident because when doctor called her by a name, I don't know where he got a name from because she didn't have a chance to introduce herself, and he called her by a name, and then she said, "No, my name is," and she mentioned the name, Miss Valida, or whatever. Yes, and I think he should have had some empathy, and because look, just listening to her, in that situation, you need to empathize and try to understand, at least let her know that you understand what is going on. You might not know everything. You're trying to get information from her. So you try to make her comfortable by showing some amount of empathy, and then, she will be able to relate to you whatever you need to know from her. Thank you.
Thank you for sharing that. Saw Parima earlier. That's Parima, if you're still on.
You there? Mommy, stop. Mommy, stop.
Okay, I don't see. Oh, they're on the call. Parima, can you maybe unmute yourself?
Good morning.
Good morning, Verlina.
Yes. So there was no report building between the doctor and the client. The client, like the doctor was just listening, and the client, like she wasn't comfortable to explain how she felt. So that was what I observed.
Thank you for sharing. Do you want to ask a few more people or give it back to you, Dr. Nikram?
No. So what we will do now, myself and Dr. Fredericks, we will go into a role play of a similar scenario handled differently, and then we're gonna find differences between the two. Sian, are you there?
Yeah, I'm here.
Okay, I'm still gonna be the patient, okay? Jana, you can time us 5 minutes this time.
Okay.
5 minutes.
You can start.
All right. Good morning. My name is Dr. Fredericks. Would you mind taking a seat? Tell me a little bit about yourself and why you came.
Sure. My name is Elizabeth, and I came today because I'm feeling a bit overwhelmed.
Oh, well, good morning, Elizabeth. Yeah, I could imagine things have been tough for a lot of people recently. Tell me why are you feeling overwhelmed today?
I feel I've been sad for a while now. It's been years. And of the past maybe 4 months or so, it's gotten very bad.
It says you've been sad for years. Can you say why? Would you remember making you like feel that way in the first place?
Well, It started when my husband's dad died. And so my husband is a doctor. And when his dad died, we went there to do a resuscitation on him. And for me, that traumatized me. I'm not a doctor. I didn't do anything. I was just basically running around trying to get the ambulance and so forth. But I do feel really sad, and it's difficult to explain because I really didn't know. I didn't know him that well, but his death has been very sad for me.
Well, I can imagine that sounds very traumatic. Anybody. It even sounds like you went above and beyond. Like you said, you're not a doctor, but you did a lot. Have you been feeling at fault for anything since then?
No, I don't feel at fault, but I just feel like I I don't know how to explain it. It reminds me of when my grandma died, and there's a lot of guilt I have about my grandma, and it just makes everything awful. And every time I see the house, or I hear some conversation that my husband is having, I feel really sad.
It sounds like you're awfully caring person. How these persons affected you and for so long afterwards. And you told me just now that things got worse recently too. Why is that? Was it something in relation with memory of your grandmother or something new?
Yeah, I'm a person that I don't like sadness. And when my grandma was sick, I stayed away from her. And when she died, I didn't go. I just went to the funeral and I was completely numb. But then I went to my father-in-law's funeral and I hardly knew him, and I cried like there was no tomorrow. So I don't know. I
Well,
can't explain it, doctor.
yeah, emotions are complex, so we can't always explain them fully. That's why we're here. We could try and figure it out. But people cope in different ways, right? You think how you responded to your grandfather, your husband's father, was in any way like related to how you felt guilty about your grandmother, or how you responded with your grandmother's death?
I felt like it made me think a lot about living and dying, and it made me think about what was the purpose of all of this. Like, are we just gonna live and then do the same thing every day and then die? And lately I've just been thinking all the time, why am I here? I can't control those thoughts.
These thoughts bother you at work, at home, all different places, different times?
They're there all the time.
How do you feel about them? How do you feel about what the thoughts are about death, about dying?
I feel like I wish I wasn't here. But it's a weird feeling. It's not that I wanna kill myself. I sort of wish somebody would kill me, or like I would get knocked down, or I would go to sleep and not wake up. And it makes me feel so guilty because everybody keeps saying, oh, life is a gift and life is precious. And I feel so bad. One, that I'm having the thoughts, and then two, that I'm ungrateful.
Time is done. Oh yeah, it was a fast 5 minutes.
All right. So clearly
Yeah, go, sorry.
Yeah. We're gonna continue this at work, okay? All right.
No.
Okay, John, can you pick some people? You seem to know everybody well on the list. Can you pick some people to just say what they think was done well or not, and then we will compare these two scenarios.
Okay, let's see. Yeah, there are a lot of new people, so I'm just gonna look at the chat and see who we have. Carolyn Court. are you on? Carolyn?
Hi, good morning.
Good morning. So what did you think about the little skit compared to the previous one?
The second skit is much more interactive, both the doctor and the patient. The doctor had open and closed question. The patient was more able to express herself. So there was a free flow of communication between them. They have to solve a problem. I think the patient has much more information and have a more, develop more, feel more free to open the doctor.
Mm-hmm. Thank you for sharing that.
That the previous kid before, it was just, he wasn't paying attention to the patient need, and wasn't an open close question to help her in anywhere. So that's my point.
Agree. Thank you. Let's see. We also have Dr. Rodrigue on it. Moses?
I would just ask.
Okay, let's see. Who else do we have on? Michael Lawrence or Michelle Lawrence, sorry. Would you like to unmute yourself? Okay, otherwise let's go to the communities again. I'll start with Chinawang again this time. What observation have you made?
In addition to what the other colleagues already said, this time doctor introduced himself, he welcomed the client, he used open-ended questions, and client was able to discuss her situation. That was my observation.
Thank you for sharing that. Let's ask in trail 47 again.
Hi again.
Hey.
Yes. Yeah, doctor, he gave her a chance. So, okay, well, he welcomed her and he made her feel comfortable, and he started to give her history, and so which is very important. And she had the opportunity to relate to him what was really bothering her, and that was really because he learned a lot from her, and he even advised her. Yeah.
Mm-hmm. Good observations. And then also, I would like to ask Parima again, Verlina, if you want to add on to that.
Yes, as my colleagues were saying, there was a proper introduction, so the client was comfortable now to explain her how she feel, and doctor was able to understand, even show empathy, and like she was more open to doctor, and she started telling him all like how she felt. And so I see it like it was more proper than we had a more communication than the first scenario.
Mm-hmm. Thank you for that.
Jana, may we
yeah.
ask Andrea Charles? I would like to hear her thoughts before we choose somebody else.
Absolutely. Andrea, can you unmute yourself?
Okay, for me, I believe that the doctor was more interested in what the client has to say. You could see that a rapport was developed there, and the client was more comfortable in sharing whatever was bothering her.
Okay. Thank you, Andrea.
You're welcome.
Before we continue, if I can just ask everyone to also put down the region they're in at the moment and maybe also their community, just for us to have an understanding of which regions we're covering right now and which communities. And then to move on, does anyone think what could have been done differently or in addition to the last skit? Is there something you would have asked first or something you would have phrased differently? I'm just interested if someone has any suggestions. Maybe, let's see, Tatiana Grant. No, or Twana?
Hi, good morning. I
Good
think
morning.
what I would have done first, I would have tried to make the patient a bit more comfortable, not talking why she came at the hospital first, just just normal chat. Oh, how was the day, how this, how that, what you like, make her a bit more comfortable. And then I would have get into, what her problem was. And compare the first scenario to the second one, because usually when you do that to patients, they're a bit more open out and they talk things that they didn't even come to talk about. So they, and then from there on, you could maybe build a friendship or something from that case. But compare the first scenario to the second one, the doctor show a bit more empathy. The first case, he didn't have any whatsoever. It's like if he was there just to do whatever is it, he was just a next patient, I want to die, everybody get issues, just deal with it. But this one, he was a bit more, interested and seem as if he wanted her not to go down that path.
That's a good observation. Yeah. I see a hand up by Cleopatra. Am I pronouncing it correctly? Cleopatra, yeah?
Yeah, that's okay. Hi, good day, everybody. I agree with what everybody has said so far. And one thing that was noted, I really, in the healthcare, in healthcare, documentation is very important. We have our patient records and so on. So the doctor in the first scenario, I feel like he wouldn't have much information on his patient in his the patient's chart, right? Because he didn't really collect a lot of information. And this information is really important to see how you're progressing, to help in possible research and so on. So the doctor in the second scenario would have a proper record for that patient, and a proper record is always important.
Thank you for that.
Jenna, maybe stop now so that we can do a summary.
Yeah, let's do that.
Okay, so rapport is very important, as we would have stated earlier, because it helps people to share more information. And it helps if there's rapport established, the patient will not only share more information, but they will also adhere to any advice or they're more likely to adhere to any treatment recommendations. So building rapport is very tricky, and the second scenario was aimed at depicting that. And basic things you do: you introduce yourself, you ask the patient what is their name, how do they want, what do you call them, basic things, displaying empathy, waiting so the patient may state whatever it is that it's bothering them. I don't know how it is in the outlying regions, but here in Georgetown, we're not really interested in making a friendship, but we want the patient to know that this is a relationship or this is an interaction where you're respected.
Collaboration.
I am here, yeah, a collaboration where I am here to help you. You are the star of this, and I want to know about you. And so good rapport building techniques involve listening, not being distracted, don't offer premature advice. So in the first session, Dr. Fredericks, all his tactics of saying, oh, everybody has problems and you just gotta deal. He doesn't know me. He doesn't know how I deal. How does he not know that I have not been to 10 different psychologists before and I know all these mindfulness tricks and whatnot, and I still am not dealing, right? So you do want to listen and you do want to ask the right questions. There are times when you can use open-ended questions, and I do encourage you to do that. Where we practice, we like to have a scouting period with patients where we give them some time of uninterrupted speech where we say, tell me what's bothering you. Tell me what has brought you here. And then we listen, and then we go off of that. Now, importantly, what is harmful to the rapport building? So definitely when he answered his phone, that would have been harmful. And I'm pretty sure that many people in the health sector, they're guilty of this, where not only on the phone, but maybe a colleague passes by and they want to drop by to say something to you, or they ask a question. And this is really disruptive to the therapeutic relationship or the collaboration. So we advise against that. Other things that we advise against are giving premature advice and having a premature analysis of the situation. Those are deadly because people don't care how much you know until they know how much you care. And you can't care about me unless you know about me. So there must be a period where you tell me where you tell me about yourself, and so that I understand your struggles and I know before I can say anything. And most advice that you will give to people, unless it's medication, they're not gonna listen to you, because the brain is so wired that if like for example, if I say, Jana, don't touch your cheek, she might want to touch her cheek, okay? So that's why we like to encourage people to brainstorm solutions to their own problems, because you're more likely to follow a plan if it was devised by you. You all hit the nail on the hammer with the interpretations of the scenario. The only thing that I want to point out is that do not give premature advice and do not have a premature analysis of the situation. If it's a new patient, usually we talk about a half an hour with them, and we get a feel of who they are, what are their days like, what do they do, before we even make a comment. Dr. Fredericks, would you like to add anything?
No. All right. No.
Okay. All right. So, yes, Henry. Sorry, Dr. Henry.
So I think a lot of, we at times we get carried away a lot, because we deal with this so much, so many times. We tend to have like a tunnel vision about as soon as a person comes in, we sometimes we tend to think, we tend to think straight to the end, so I really like that part where you said that we shouldn't have we shouldn't just jump to conclusions basically about what this patient might be going through. Okay, I think that's really important. Another thing I think too is patience. Patience, give the person time to speak, give the person time to express what they're really going through. I think you touched on that a little. And sometimes you might forget in your interview, or you might just miss some important things that the person might think is really important. But some people, if you don't ask them, they're not gonna talk about it. So I think at the end you can say, listen, is there anything that you feel is important that you didn't mention before? And then maybe you can have a discussion about that as well.
Absolutely. Yeah. We do that in every time we talk to everybody. We always say, is there anything that you'd like to tell me that I didn't ask you? And the floor is open to them. If just my personal opinion as the patient of the two scenarios, for the guy in the first scenario, I just felt that doctor was so smug and full of himself, and he really didn't care about me. And so it did feel really bad, even though it was just a skit. So I can imagine how when the patients come, if you're that way with them, for the therapist or the doctor or the nurse, this is just another patient. But for the patient, you are my line of hope. You are the person that's gonna pull me out. And so you're very important to me. So that's why it's really important that I pay attention to the way I treat you. All right, Jana, that's all I wanted to mention.
Oh, well, before we move on, I guess it would be good practice. I know it's like already asking a lot, but dealing with patients, not these patients just one after the other on a daily basis is taxing. So I think as practitioners, nurses, doctors, whoever, it's good to just take time for ourselves, reflect on how we feel about certain situations, do all of those good stuff in order to better build rapport with patients. Because sometimes you as the individual might just not be able on the day. And you gotta, take some pause before you engage.
I would like to add to observe doctors that came from some discussions we have with community members. Most of those communities are very small and rumors fly around very easily. So one of the things that's really important is keep confidentiality and tell the patient that everything that you guys are talking about, you will not talk to anybody else in the community. That they can trust you, that you build the fact that this is not going to start a rumor mill immediately once they go in and talk to you. Something else, and maybe you can explain better how to do it within the context of the communities, but we heard from one family who said, we don't really like going there because the moment we go, the health worker will tell it to everybody in the community. So think about who they trust and how you can really verify that confidentiality, which also means maybe if you have to sit with them in the clinic, go into the room, put a sign on the door that says, do not disturb, leave your phone outside, and then walk into a room, close the door behind you, sit and engage them. Have your attention 100% on the person you are talking to and verify they know that you're 100% focused, that you're not distracted by other things that are important for you. That sends a very important message when you handle it this way.
Yeah.
Anything?
Sorry, just to add to that, we normally do have a little speech that we give to everybody, and where we say the time that the session will take. I don't know if the other people will do this, but usually I would say this session I will be talking to you for about 30 to 45 minutes. I will ask you some personal questions. And if you feel like you're not comfortable answering them, you can just let me know. Everything you tell me is confidential, and I will only share it with the other team members if I feel like you're a risk of harm to yourself or others.
Yeah.
Thank you.
Okay, Johnny, do we move on from rapport? Maybe we can revisit this as another time. It's something that you can't teach in one session. You do need practice. You do need simulations, and so maybe on a next call, maybe we can do the simulations and use the participants.
Yeah, let's see. I think this is pretty much a summary of what we had, and then this as well. So maybe we can switch to Dr. Henry. He wanted to talk about the safety plan.
Dr. Henry, I think you might be on mute.
There we go. Now we can see, and yeah, you're still muted, Dr. Henry. You're still muted. There we go.
Okay. Okay, so here we have a slide with basically we created kind of like a safety plan, when when patients who have suicidal ideations, you know, we can introduce this to them, or we can use these these steps here. Okay. So the first one is, of course, you have to learn to identify the warning signs. I think Dr. Nikram, Dr. Fredericks did mention some of those. All right, but some of these things can be pretty simple, you know. Things like maybe a recent death, maybe. You know, when you have a recent death, the grief is really unbearable at times. Okay. If you have like you feeling hopeless, worthless, or trapped, feeling guilt, shame or anger about the situation. And I think one of the most important things is like if you had a suicide attempt before, if the person had a suicide attempt before, well then the likelihood that they're going to try again is increased a lot. Okay. If behavioral changes, like if you notice the person has started drinking alcohol more than before, or even other drugs as well, marijuana, cocaine. I think in Guyana we have more like things like ecstasy and crack cocaine as well. Okay. Suddenly they start they change their personal appearance. They're looking shabby. You know, and they're not as crisp and like before. You know, I see a picture of Dr. Sian, they're dressed up in his tie and stuff. You know, and then if suddenly he came and he was all shabby and stuff like that, well then, you know, it's something that's definitely wrong. Okay. Withdrawal from isolation, withdrawal from your friends, withdrawal from your family, at work, from your colleagues as well. And then things that you can get really worried about is if the person actually leave or tell you, you know, listen, I'm actually thinking about suicide, or they leave a suicide note, okay? Or they start saying goodbye to everybody and giving away their stuff, making a will, for example. All of those things are warning signs. I think they touched on that a lot the last presentation. So next we do internal coping strategies, things that you can do or person can do to take their mind off their problems without contacting another person. All right. In the interest of time, we can probably do one. There are lots of things you can do. One of the most simplest things is the 5, 4, 3, 2, 1 method. Okay, so you tell the person, or you know, somebody calls you and says, "Listen, I have suicidal ideation. I don't think anybody can stop me." So you can calm them down. You first build your rapport, you calm them down, and then you can introduce this. Okay, so you can ask them to say out loud 5 things that they could see. All right, and ask them to really look at them and observe them. So we use our senses. Okay, remember we have five senses. Okay, then you ask them to touch 4 things. Then touch 4 things that are close to them and really feel it. Okay, feel the contour, like for example, if it's a table, they're feeling like the cracks, and they can explain it. Okay, and then 3 things you can hear and really listen to them. You know, it kind of brings them back to reality. You know, that they're here and present, that there's things going on around them. Okay, and then identify 2 things you can smell. Sorry.
I think we lost Dr. Henry. Dr. Nikram or Dr. Fredericks, are you familiar with the plan and could maybe finish it up? if he doesn't join on time. Dr. Nikram?
Okay, Jana, I have a bit of noise on my end, okay? So I think Dr. Henry got up to people and social settings that provide distraction. Was that where he was? Yeah, so
Correct.
so basically the safety plan is centered around identifying triggers that might cause you to have the thoughts. What are the warning signs that I am having the thoughts? And then how can I cope? Who can help me? Who can I reach out to? What are things that I can do to distract myself? That would be the step 3. And then who can I ask for help? Sian, please continue. I have a bit of noise here. I have to
That's
attend.
okay. That's okay.
Okay, no problem. I think just considering the time, I think we have to wrap it up slowly. So maybe Dr. Sian, I will share the slides with everyone who puts their email address in the chat. And you will also get a recording of the session so you can share it with your colleagues. So maybe Dr.
Yeah.
Sion, you can guide us through some of the resources available in Guyana for people to reach out to. This is
All
what I
right.
saw planned from Dr. Henry.
Yeah. So we have the main facilities, the Georgetown Public Hospital Mental Health Unit. This hospital has the psychiatric department. We're fully stocked with, multiple psychiatrists, psychologists, social workers available. The mental health unit has psychologists available for persons who require therapy. There's also a drug counselor, so that's not there. So these are some of the numbers for them. Obviously, at the hospital, you can just come. What we usually advise is that if you're having concerns with yourself or a family member, you share it with a doctor at a health center. A lot of times, a lot of how you feel might be associated with a medical illness. So it's always good to have that checked out and sorted first. Or the doctor can just simply just do a referral to come to us. But if you show up off your own, that's fine too. We can facilitate you within a reasonable time frame. Also, the Georgetown Hospital, we do satellite clinics. Dr. Henry was mentioning a few. So we assist in Region 3. There's a psychiatrist stationed in Region 3, where we assist with clinics in Perical and Nora. There's also clinics at Westdam, Parfit Harmony, Bell West, Leguana, Wakenham as well. We go to Bartica, we go to Suddy twice a month, and we recently have a doctor stationed at Region 5 as well. So now there's psychiatric services available within Region 5. And well, we would tend to visit Region 1, Region 9 as well, but we have the telemedicine system, fortunately. So basically services can be given nationwide. I'm not really too sure about the regional clinicians that I'm seeing here. I don't know if or when training was done, but I do know there are quite a few MHGAP trained individuals in each region. So maybe these were persons who were well, Dr. Henry, obviously, but maybe these were
Yeah,
persons.
so these were
MHGAP
persons
trained.
identified to basically identified and who agreed to basically take calls from people who were doing a study. The people who attempted suicide. We had people interviewing them, interviewing their family as well. And these are people who agreed to have it's like clinical backup. Okay. As you can see, my name is there for Region 4. I'm not the only person in Region 4, but for you guys feel free to call me anytime or message, from the other regions as well. I think we're pretty open to that. Dr. Nikram and everybody else in the department, really. So these names are not like fixed, You can call us for advice if you like, no problem.
Okay, great. Thank you.
Yeah, I second that. Jonna, if you want, you can put my number there. Yeah, people can call for advice. Normally, the family medicine physicians, they usually do call me, and I welcome call from other people too. Calls.
Okay, good. I will add your name, or you have access to the slides because you also wanted to add 2 terms, correct? That weren't listed.
I didn't check to see if I had access to the slides because really I just wanted those 4 sentences, but I'm pretty sure Sian will add it. He's
Okay.
very familiar
worry.
with the gesture and threat.
Okay, that will be possible. I'll let you name. Okay, thank you, everyone. This brings us to the end of the webinar. Yeah, I will, if you put your email in the chat, you will receive an email with the recording of
Jana,
you to
you
the
lost audio.
Oh.
Were
No,
you
just
saying
make sure-
goodbye?
Just make sure your information is in the chat, so we can make sure that everyone receives the recording and the slides. But I just want to say thank you to you, Dr. Nikram, Dr. Fredericks, and Dr. Henry for taking the time today to talk about rapport building and suicide prevention, but also for everyone coming out on a Sunday morning early. So thank you for that.
Always welcome.
Jana.
Yeah, okay.
Jinx, Sian, you gotta buy me a Coke.
I just wanted to say thank you to Yana for organizing the event, and thank you for your community, health workers and teachers and nurses who have been on the call. We are asking a lot from you. This is not easy what we have tried to share today, and we know that, but the suicide problem is significant. And you are in the forefront and have the best ability to help. So please reach out if you need more information. If something is not clear, tell us. But we really appreciate you coming here early morning and share the knowledge with other teachers, other health workers, and reach out to us and the doctors if you have any questions or ever any individual in the community that you think might need help and you want some guidance. Really appreciate it, and hoping that we can all make a difference together.
Okay, thank you, everyone. I will copy the.
Jana,
Thank you.
I think it's important to thank you and your dad too. Because none of this would have happened had y'all not had this idea. So thank you for having an interest and for following through on that.
Yeah, let's make sure we'll have follow-up sessions. I think there is much more we need to discuss. But for now, I think everyone can go and enjoy the Sunday and think about what we learned today. So I ended the chat. I got everyone's email. So thank you, everyone. And hopefully
Thank
I'll
you,
see you
John.
next.
Sorry we
at the
couldn't
next-
join you for the coffee and the pastries.
Especially the pastries.
No worries. I'll invite you guys. Okay.
Thank you, Chiniwang. Thank you, Trail 47. Bye.